Hello everyone. This video recording is to teach you how to do the diagnosis, then write a problem list, etiology of malocclusion, treatment aims, and then the treatment plan for the orthodontic case. So I'll give you this case as an example. For this patient, we have a profile view, then frontal view, then intraoral photos. I'm going to take you through this case to show you how to do the examination and the problem list. So we start with a skeletal examination. As you can see, the anterior-posterior relationship for this patient is a class 2 skeletal. If you look at the etiology for the class 2, you can see that the mandible is retruded. If you drop the 0 meridian line, you can see that the mandible is retruded. So basically, he's a class 2 skeletal due to retrognatic mandible. That's the examination. Then looking at the vertical skeletal relationship, so you can see that he has an increased lower facial height and he has a posterior growth rotation. So vertically, he has an increased lower facial height due to posterior growth rotation. Then if you look at the transverse relationship, you can see that he has no clinically significant asymmetry. So we're done now with a skeletal examination. Anterior-posterior, he's a class 2 skeletal due to retrognatic mandible. Vertically, he has a increased lower facial height due to posterior growth rotation, and transverse, he has no clinically significant asymmetry. Then if you go to the soft tissue, you can see he has an incompetent lips, and that because of the posterior growth rotation and increased lower facial height, and could be as well because of the class 2 skeletal relationship. If you look at the lips, the nasolabial angle is acute, it's a reduced nasolabial angle, and that's because of the anatomy of the upper lips. You can see that the lips are reverted. So now the soft tissue examination, incompetent lips due to posterior growth rotation and increased lower facial height, everted lip, acute nasolabial angle due to the everted lips. Then we go to the intraoral examination. But before we go to that, just check the midline. You can see that the upper midline is shifted to the left by 3 millimeters. So go to the intraoral examination. We start with the oral hygiene. You can see that his oral hygiene is slightly poor, and we have multiple decay. We have a remaining root for the E. We have a badly destructed 6. We have a missing 6 here. So oral hygiene is poor. Then if we look at the intraorally as well to the upper arch, we can see that we have a badly destructed 6, and we can see here that we don't have a canine. And the canine, the bulge of the canine is here. So the canine is impacted. Now, if you look at the crowding and you need to measure the crowding, you can see that we have a moderate crowding in the upper arch. And you have a little bit of spacing here, which is about 1 millimeter, and the canine is around 8 millimeters. So we have 7 millimeters of crowding, which count as a moderate crowding. Now the question is, what is the etiology? Why do we have an impacted canine, a moderate crowding, and we have a midline shift in the upper to the left by 3 millimeters, which is the same side as the impacted canine? Now, a piece of advice, whenever we have a crowding, we always think about tooth arch size discrepancy, which means that the size of the teeth is bigger than the size of the jaw. But when you have tooth arch size discrepancy, the crowding will be similar on the right side compared to the left side. So on both sides, you will have the similar amount of crowding. But when you have a crowding more in one side compared to the other side, that's an indication that we have local factor involved here. So if you can look at this case, we don't have any crowding or even like 1 millimeter of crowding on the right side, but we have a moderate crowding on the left side. So we have more crowding on one side than the other. So tooth arch size discrepancy could be a factor here, but it's not the only factor, because if it's the only factor, then you have crowding in the whole arch. But because it's more in one side, then we have a local factor. So what could cause a midline shift of a 3 millimeter and a crowding? It's a premature loss of a primary tooth. But because the midline shift is a 3 millimeter, then the premature loss of the C will result in that. If we don't have a midline shift, but we have crowding, that's usually premature loss of the E. If we have a little bit of a midline shift, like a 1 millimeter midline shift, mesial migration of the posterior teeth, then that will be a premature loss of the D. But because in this case we have a midline shift of 3 millimeter, that's a premature loss of the C. Then, why is the canine affected? Because it's the last tooth to erupt in the arch. So for that reason, the canine is the last tooth to erupt, so the canine became impacted. Now, let's go to the lower arch. You can see here we have a spacing due to the extracted 6, but look at the lower arch, we have a crowding on the anterior labial segment. If you measure this crowding, again, it's a moderate crowding. And also if you look at the midline, you can see that we have a huge midline shift of the lower to the right side. So we have 3 millimeters of the upper to the left, we have 3 millimeters of the lower to the right. So we have a midline shift to the right, and we have moderate spacing. Now, you can say that we have a lingually displaced lateral incisors, lower right lateral. So what is the etiology for all these problems? Lingually displaced lower right lateral, moderate spacing, and midline shift. Now, in this case, tooth arch size discrepancy is there because we have crowding definitely. But again, why do we have crowding more on one side? And why do we have a midline shift to the other side? So again, we have a local factor involved. Is it a premature loss of primary tooth? The answer is no. Because in this case, if we have a premature loss of the C, the lateral incisor erupted before the canine, before the premolars. So basically, if we have a problem with the premature loss, the lateral incisor has all the space to erupt. But because the lateral incisor erupted before the canine and the premolar, the lateral incisor decided to erupt lingually. And that's because of the ectopic position of the tooth bud that erupted lingually. So then the teeth shifted toward the place where we have crowding so that we have a midline shift. So the etiology for the malocclusion here, we have midline shift due to the ectopic eruption of the lower lateral incisor. The lower lateral incisor erupted ectopically because of the ectopic position of the tooth bud, and we have crowding because of the tooth arch size discrepancy. Then let's go to the anteroposterior, vertical, and transverse occlusion. So if you see the incisor relationship, it's a class 2 division 1. Overjet is 6 millimeter. A canine relationship on the right is a half unit class 2, molars is class 1, while on the left side we don't have a canine, and the molar relationship according to the premolars, because we don't have 6 here, is a half unit class 2. Now I want you, whenever you think about any relationship, so whether it's dental or skeletal, you have to think anteroposterior, vertical, and transverse. So now anteroposterior dental relationship, class 2 division 1 incisors, and overjet 6 millimeter, molars and canines. Then vertical relationship is the overbite. So here in this case, the overbite is normal, complete, and atraumatic. Now if you think about it, why do we have a class 2 division 1 incisors? Why do we have increased overjet when we have class 2 buccal segment? All of them because we have a class 2 skeletal. It's an anteroposterior problem. Now then look at the transverse relationship. We have a midline shift. We have a midline shift in the upper to the left by 3 millimeter, in the lower to the right by 3 millimeter. And as we mentioned before, the etiology for the midline shift in the upper because of the premature loss of the C, while in the etiology of the midline shift in the lower is because of the ectopic eruption of the lower right tooth. Now, also in the transverse relationship, as you can see here, that we have lingually crossbite of the of the lower right 5. You can see here is the palatal cusp of the upper 5. So if you can think, what is the etiology for this lingually crossbite? If you can say small mandible, for example, you should have all the teeth involved, not only one tooth. So if you have only one tooth, that again indicate that we have a local factor. What could be the local factor? Either crowding or ectopic tooth bud of the lower 5. Good. So now how are we going to write the problem list? And that's what I'm asking you to do in the clinic. I'm going to be asking you to represent a problem list with the etiology for this problem. We always have to be structured when we present our problem list. Structure is the main key. So you're going to start with your pathology, then chief complaint of the patient. Then we go skeletal, soft tissue, and dental. And when we do the skeletal, we have to go anteroposterior, vertical, and then transverse. When we do the skeletal dental, we go anteroposterior, vertical, and transverse, and then we go lower arch and then upper arch. Now, remember, it's called the problem list, which means if you don't have a problem, you don't write it down. So, going back to our case, starting with the pathology, we have a multiple carious teeth. And what is the etiology for these multiple carious teeth? It's due to poor oral hygiene and diet control. Patient has poor oral hygiene, he has a poor diet control. Then, what is the chief complaint of the patient? He said, I have an extra tooth, crowding. Now, coming back to the skeletal relationship, we go anteroposterior, vertical, and transverse. So the anteroposterior relationship, he said he has a class 2 skeletal due to retrognatic mandible. Then vertical, he has an increased lower facial height due to the posterior regrowth rotation. Now notice that in the transverse, we have no problem, so we leave it empty. If it's not a problem, we don't write it down. Then in the soft tissue, he has an incompetent lips, and we mentioned that because of the posterior regrowth rotation that the patient has, and maybe you can add because of the class 2 skeletal, it's fine. Then he has a reduced nasolabial angle, as we mentioned, it's because the everted upper lip. Then dental, we go anteroposterior, vertical, and transverse. Anteroposterior, overjet, molars, canines, and incisor relationship. All of them are caused by the class 2 skeletal. Then you go to the vertical. Notice again, vertical, there's no problem. Patient has a normal complete overbite, so we don't write it down. Then transverse, we have a lower midline shift to the right by 3 millimeter, and we mentioned that this is because of the ectopic tooth bud of the lower right tooth. And we have upper midline shift to the left by 3 millimeter, and again, this is due to the premature loss of the upper left C. We have a localized lingually crossbite of the second premolar without displacement, and this is caused because of the ectopic tooth bud of the tooth. Now, we finished now dental, anterior, posterior, vertical, and transverse, we move to the lower arch. In the lower arch, you need to mention about crowding and spacing and the position of the teeth. So here we have ectopic lower right 2, and that's because of the ectopic tooth bud. We have moderate crowding, and that's opposed to ectopic tooth bud and tooth arch size discrepancy. Now notice the midline has to go in the transverse relationship, not in the each arch. Each arch individually, you mentioned the position of the teeth and the crowding. In the upper arch, we have an impacted upper left 3, and we mentioned that's because the premature loss of the upper left C. And you can add up as well because of the canine is the last tooth to erupt. And we have moderate crowding again due to the premature loss of the upper left C. So now you have all the problems that we have. Then the next step in the treatment plan is to decide what are our treatment aims. What are we going to treat and what we're going to accept. So basically your treatment aim should be the same thing as your treatment, as your problem list, but whether you're going to treat or whether you're going to accept or whether you're going to camouflage. So starting with your problem list, we have caries. Are we going to accept this one? Definitely not. So we have to treat it. So we're going to say restore caries and improve oral hygiene. That's your treatment aim. Then you go to the skeletal relationship. Patient is 15 years old, so he passed the growth spurt. He's not severe to go for surgery. So are we going to correct the class 2 skeletal? The answer is no. We're going to either, we call it camouflage the class 2 skeletal or accept the class 2 skeletal. Now, regarding the vertical relationship, he has a posterior growth rotation and he has increased our facial height. We will accept this one. We don't have anything to do with that one. Then we go to the soft tissue. He has incompetent lips. Our job as an orthodontist, we have to correct the competent lips. And that will improve because when we extract the teeth and retract the upper incisors, the lip competency will improve. So yes, we have to correct the lip competency. However, regarding the nasolabial angle, because it's due to the shape of the lip, we're going to accept this nasolabial angle. So in your treatment aims, you should say achieve competent lips. I don't want you, the clinic, to say treat the incompetent lips. No, the answer should be, I know that I explain it to you in a way, accept or treat, but you need to tell me how you're going to treat it. So achieve competent lips. That's how you should write it down. For the nasolabial angle, say accept the decreased nasolabial angle. Then we have an overjet, incisors, molars, and canines. Are we going to accept or are we going to treat? We're going to do a full comprehensive treatment for this patient. So I'm going to correct the incisors into class 1. Canines into class 1. It's always like this. Whenever you treat a patient, we always have to finish in a class 1 molars, class 1 canine, and the normal overjet, which is 2 to 3 millimeter. But the molar relationship, it depends on your treatment plan. If you're planning a non-extraction treatment, then your molar relationship should be class 1. If you are planning an extraction in the upper arch only, your molar relationship should be class 2. If you're planning extraction in the lower arch, your molar relationship should be class 3. If you're planning extraction in the upper and lower, then your molar relationship will be a class 1. So you need to mention what will be your final. Don't write for me treat the molar relationship. That's not an answer. You need to mention achieve class 1 molars, achieve class 1 canines, achieve class 1 incisors. That's how you should write your problem list, your treatment aim, sorry. Then vertical problems, we have nothing. Now here we have a midline shift. Are we going to correct or are we going to accept? We're going to correct. So you're going to say correct the midline of the upper, correct the midline of the lower, and correct the crossbite. Then we go to the lower arch. We said we have an ectopic lower right 2 and we have crowding. So you say align lower right 2 and relieve crowding in the lower arch. Same thing with the upper arch, align the canine and relieve the crowding. So your aims and objectives should look like this. Restore carious teeth, accept class 2 skeletal, accept increased lower anterior facial height and posterior growth rotation, achieve competent lips, accept nasolabial angle, achieve normal overjet, class 1 incisors, molars, and canines, because in this case we decided to go for extraction in the upper and lower, correct the upper and lower midlines, correct the lingual crossbite, relieve crowding in the upper and lower arches, and align lower right 2 and upper left 3. Now, after you're writing your aims and objectives, you just need to mention what is your type of appliance treatment. Are you going to do camouflage, growth modification, or surgery? We believe that this is camouflage case. Then what is the type of the appliance? We have 3 types of orthodontic appliances: removable, fixed, and functional. The patient is a grower, we can go for functional. He's not a grower, so functional is out. Then removable appliance. Now remember, removable appliance are only able to do a single or 2 teeth movement, and the tooth movement is only tipping movement. So whenever you need a bodily movement or a multiple tooth movement or treatment in the lower arch, that's an indication for fixed appliance. Now, growth has nothing to do with removable or fixed appliance, because you can fit a removable appliance for 50 years old patient. It depends on the type of the tooth movement that you are doing. Removable appliance, remember, single or 2 teeth movement with tipping movement only. If you need bodily movement, multiple tooth movement, treatment in the lower arch, then you have to go for fixed appliance. And thank you for listening.